Good evening and welcome to the second Nestlé Health Sciences webinar on children with neurodisability. This time we're going to be looking at children with neurodisability, the challenge of meeting nutritional requirements. We've got three presenters tonight. I'm going to start off presenting. We're going to then move to Lindsay Rosie, who's going to talk to us about tube feeding with low energy requirements. And then we're going to finally come to Jodie, who's going to talk to us in terms of how to look at growth measurements, particularly at home over this very difficult period when children are not as able to access healthcare as they were previously. So in terms of a little bit of housekeeping, just so you're aware, if you look at the bottom of your screen, there's a Q&A tab. That would be the place to put your questions. We'd absolutely encourage questions. Please put them in throughout the presentations. What you ought to be aware of, however, is that we're recording this ahead of time. So we're not going to be able to answer the questions during the presentations or between the presentations, but at the end of the presentations, we're going to move to a live session of which all three of us are going to be present, and we're going to spend 20 minutes or so at the end of the presentations answering your questions. So we'll start, and the first presentation is myself. Now, I've been asked if I would talk about important considerations to ensure optimal nutrition in the neurodisabled child. What I was asked to talk about is looking particularly at challenges for healthcare professionals when we're looking at the nutritional needs of children with cerebral palsy and other neurological disorders. We've asked if I would try and think through and develop a better understanding of why neurodisabled children have unique nutritional requirements. And then we're going to look at both the ESPGHAN and the NASPGHAN guidelines for the nutritional management of poor feed tolerance. The ESPGHAN guidelines came out in 2016 and the NASPGHAN guidelines in 2006, and they're both really useful documents to try and help us manage this group of children. What I thought I'd do is to set the scene to start off with. This is going to be a difficult, perhaps, slide to start with and explain to you, but this was done in Western Australia, and this is looking at the survival and mortality of children with cerebral palsy, and this is in the more severe group of patients. What I wanted to highlight to you is the sort of purpley line, because that is the children born between 1991 and 2000. And what you can see is that their survival in the first decade of life and into the second decade of life actually was better than previously. But there seems to be a really sudden drop-off towards the end of the second decade of life. The authors don't really understand completely why that is, and I think it's partly because the death certificates tend to have a respiratory death, but they postulate through their discussion that actually it's nutritional issues, particularly severe foregut dysmotility, reflux, aspiration pneumonia, and almost intestinal failure that we're beginning to see more and more in this second decade of life. When we look at the prevalence data, we can see that though overall there's about 2.1 patients with cerebral palsy per 1,000 live births, we're all aware that this increases dramatically in those neonates weighing less than 1,500 grams. In terms of setting the scene, we really need to be aware that 85% of children with neurological impairment have feeding difficulties, which affects not only their health but also their quality of life. We're all aware that they have marked gastrointestinal problems, gastroesophageal reflux disease, constipation, dysphagia. And complicating the matter further is that they nearly all have a comorbidity. Now, that might be epilepsy, the use of anti-epileptic drugs, scoliosis, but again, that makes their nutritional management that bit more complicated. The other thing I wanted to flag up is that we are also aware that children with cerebral palsy do not grow normally. The reasons for this is multifactorial and really beyond the scope of this talk, but it's not only nutritional. You know, the nutrition is definitely part of it, but there's neurological reasons, there's comorbidity reasons, there's medication reasons, there's endocrine reasons. But what we see when we look at growth in children with cerebral palsy compared to typically developing children is that if we look at the graph on the left, this is boys in GMFCS level 1, and on the right is girls who are GMFCS level 5 who are tube fed. And you can see, though in the less severely neurodisabled children, their growth is closer to typically developing children. Certainly in the more severe end of the spectrum, the growth is very different, particularly over the age of 10 years. A group in California actually looked at 25,000 children with cerebral palsy and took over 100,000 measurements from them, and have developed growth charts specifically for children with cerebral palsy. And they found that the centiles change both on sex and, as you would expect, on the severity of the neurological impairment. And what they found was that if you were in the bottom 20% of the weight centiles, particularly at the more severe end of the neurodisability spectrum, that you would have an increased risk of mortality. So if we wanted to set the scene further, so poor nutrition in children with neurodisability, what does the evidence show? Well, it shows that they have a greater number of secondary and chronic health conditions, that they have increased healthcare utilization and decreased participation in school and family activities. They have an increased risk of lower respiratory tract infections, and when they get those infections, they get over them a lot more slowly, and that was felt to be due to the decreased immune function seen with poor nutrition. If the children need surgery, there's impaired wound healing and a longer post-operative length of stay, and as I've mentioned, a definite increase in mortality. But of course, what are we aiming for? If we can get the nutrition better in this group of children, what can we achieve for them? Well, without a doubt, all the evidence shows we improve health and quality of life. It decreases irritability and spasticity, and it increases alertness and enhances developmental progress. And actually interesting to me, because I have to confess I didn't know this until I did some background reading for this talk, was that there is some limited evidence that actually if we improve nutrition, we can help or in some cases ameliorate gastroesophageal reflux. So the studies that show children with poor nutrition having a pH impedance study, improving their nutrition, repeating those measurements and showing that they normalize. The other thing to say when we're setting the scene, however, is that a small proportion, 8 to 14% of this group of children can be overweight. So if we jump now to the challenges, now obviously there's multiple challenges in this group of patients. So I've tried to select, the top 4 or 5 to talk to you about. I think the first must be which is the right growth chart to use. And I've shown you that there are CP specific growth charts now, but what the ESPGHAN guidelines say quite clearly is that they do not recommend the use of those growth charts. I think that's partly because it's in a specific and overall not a large group of patients, but also because the growth charts show how a group of children with neurodisability are growing as opposed to how they should be growing, if that makes sense. So what we're really suggesting is that for children with neurological impairment, we should use typically developing children growth charts, standard growth charts. But of course, that jumps us to the next challenge. Growth charts in many ways are meaningless unless we can get measurements for both height and weight. And we're all aware that actually measuring the height in children with complex neurodisability is difficult. They often have scoliosis, contractures, and other reasons why measuring height is very difficult. However, we need to all be aware that segmental leg length measurements are extremely well validated and they correlate strongly with height. And though some of them need the special calipers, you can measure tibial length just with a pure tape measure. So I'd very much encourage people looking after this group of patients to get good at doing that. What you do once you've got that measurement is you can either plot it on a segmental length growth chart. So you would plot this length for an 8-year-old child on the segmental length growth chart. You would find they sit on the 25th centile line, so then they've got 25th centile line height. The alternative way is you could take that length and then using a standard equation convert it to a height and then plot it on a standard growth chart that way. So in that way we very definitely can get height and weight measurements. However, it brings us to our third challenge, which is that weight for height is actually quite a poor indicator of malnutrition in children with neurological impairment. What we know is that weight for height, less than the 10th centile, identifies only 55% of children with malnutrition. So the ESPGHAN guidelines recommend that we measure fat mass by skin fold thickness, and that should be a routine component of nutritional assessment in children with neurological impairment. And they highlight that a decreased tricep skin fold thickness identifies 96% of children with malnutrition when more complex body composition measurements are used as the gold standard. So finally, if we come to challenge 4, what other ways have we got of looking at undernutrition in this group of patients? So ESPGHAN say one or more of the following red flags are warning signs of undernutrition. So we should physically examine the children. Any sign of any skin ulcers, decubitus, skin problems, or poor peripheral circulation would be a red flag. A weight for age Z score of less than -2. Triceps skin fold thickness less than 10% of the centile for age and sex. Mid-upper arm fat or muscle area the same. But as I say a lot in my clinical practice, the crux of actually measuring these children really is that we need to do longitudinal measurements. And so if we see faltering weight or growth fault or failure to thrive, that would be a very clear clue that we're not meeting their nutritional requirements. And part of what Jodie's going to come to later in this group of presentations is to talk about how we can manage to do that even under these present COVID situations. What the ESPGHAN guidelines say is that in infancy, we should be getting sequential measurements at least every 1 to 3 months, and in the older child with a neurological impairment, at least every 6 months. So the main part of my talk I was asked to do was talk about poor feed tolerance. Now, we all know what that means in children with neurological impairment, that they have vomiting, they have esophagitis, and there's this very difficult volume intolerance problem. So we recognize in clinical practice that actually these children are incredibly volume sensitive. We can go from 24 mils an hour to 25 mils an hour, and the family will know that's the trigger, that's where they start vomiting. One of my frustrations is that the way that's managed practically it would tend to be actually reducing the feed volume. We're going to talk about in a minute that these children actually have lower calorie macronutrient requirements, and therefore you can actually take a 1 kilocalorie per mil feed down in volume, or we can use a 1.5 and use an even lower volume. But though we're meeting the children's macronutrient kilocalorie requirements and maybe they're gaining weight normally with that, we need to be very aware that we're often not meeting either their fluid or their micronutrient requirements. So if we look at the energy requirements of a child with neurological impairment, I can't talk about it in great detail, but I think this is just perhaps something to help. I think the dietitians among the audience will be very aware of how to do this, but really for the medical staff and maybe the nursing staff, this might be helpful. So it's worth thinking things through, and there's different aspects of each child which will impact on how many calories or macronutrients they're likely to require. So this is a formula that was put together by Crick in 1992, and what they look at is looking at the resting energy expenditure, which is utilizing the WHO equation specific to age and gender. We times it by muscle tone factor times activity factor plus a growth factor. So complicated calculation to really try and understand what kind of calorie requirement this child might require. So the muscle tone factor would be perhaps 10% for higher tone, but subtracting 10% for lower tone, no adjustment for normal tone. Activity factor, 15% for bedridden state, add 20% for wheelchair dependency, add 30% if they're ambulatory. And growth factors would be 5 kilocalories per gram of expected or desired catch-up growth. But that's only one formula. There's other formulas, so I put some up here. So I'm looking at basal energy expenditure, indirect calorimetry, or height. But the basic message with these is that this is really just our starter for 10, if you like. This would be our first guess at how much energy this specific child would need. What we need to do is start them on that and then monitor them very carefully and then adjust up or down depending on their growth. Fluid requirements. I think what all of us know that look after this group of patients is that many of them are surviving on far less fluid than we would give to a typically developing child. And one of my frustrations is when people phone me and say, well, actually, though they're on this very limited amount of fluid, they're fine because they're not showing any signs of renal impairment or renal failure because of that. However, I think we need to recognise that the amount of fluid these children require, it's not really just looking at their renal function. Often they have an increased fluid requirement because of drooling, but actually quality of life and symptoms are important too. And we all know that when we're thirsty and we're dehydrated, that gives us unpleasant symptoms. We need to be aware that's the same in this group of patients. And I think we also need to be aware that the constipation we see is in part at least due to chronic dehydration. So what the ESPGHAN guidelines say is that we need to pay careful attention to the hydration status. But I would also add to that it needs to be more than just are they showing renal impairment. Micronutrient requirements. I think a lot of you may be shocked to see that deficiencies for iron, zinc, copper, vitamin D, carnitine, folic acid and vitamin B12 are common, with percentages ranging between 10 and 55% of the neurologically impaired group. I think some of that is perhaps because of what we've been talking about, reducing the standard feeds to lower volumes, but there's other factors. Vitamin C is no doubt going to impact on the iron absorption. The use of anti-epileptics can impact on carnitine, vitamin B12, folic acid, calcium and phosphate. And a lot of these children have reduced exposure to sunlight, which obviously impacts on vitamin D. Overall, tube feeding and the use of nutritional supplementation were associated with higher concentrations of micronutrients. We come to bone health. I don't think we can understate, or we've overstate even how important this is for this group of children. So when we look at the mean bone density Z scores, the distal femur is the most important part because this is where we tend to see the pathological fractures. And the prevalence of distal femur bone mineral density Z scores of less than -2, which puts you in the at-risk zone for fractures, is more than 70% of these children. And the annual incidence of fractures is 4%. And they found that the significant determinants of a low BMD and the greatest risk of fractures are seen, as we might expect: limited ambulation, feeding difficulties, previous fracture, anticonvulsant use. Interestingly, the increased fat mass, and I think that's probably as a sign of the group of patients that have this more than ever that have this problem, because these are the group that are perhaps requiring lower amount of calories coming through, and gastrostomy use. And again, I think the gastrostomy use is more just an indicator of the group of patients that are more at risk. So what does the ESPGHAN guidelines say? The ESPGHAN guidelines say that they recommend the DRI for micronutrients in typically developing children to estimate the appropriate micronutrient intake for children with neurological impairment. This was certainly one of the questions that came up for me at the end of the last webinar that we did. They recommend the use of DEXA scans regularly as part of the nutritional assessment in neurodisabled children. And I think certainly within the UK, that's probably not something we do in a widespread manner. They recommend the routine assessment of a micronutrient status, and they state that should be done annually. And I think that's very important also. If we come finally to the last part of my presentation, I was asked to look at what do the ESPGHAN and the NASPGHAN guidelines tell us about managing poor feed tolerance. The first thing to say is we can start with more straightforward measures. And if we look first, they talk about high pectin diet significantly decreases reflux and all aspects of reflux. I have to say this is something that I've not done a great deal in my practice, though I did have a dietetic colleague while I worked in Newcastle who was very keen on this, and we did indeed see some definite improvements in reflux and vomiting in children where pectin was used. They've shown very clearly that there is a reduction in the amount of reflux seen when whey-based rather than casein-based formulas are used. So that's an important consideration, particularly if we're having increased vomiting and difficult feed tolerance. And also, as I've mentioned already, that malnutrition itself seems to influence gastroesophageal reflux. So actually improving the nutrition in these children is an important part of the management. What do the guidelines say about PPIs and motility agents? Well, they say that a PPI is definitely superior to an H2 blocker, both for the healing of erosive esophagitis and for the relief of symptoms. Importantly, they state that PPIs do not influence the volume of the reflux, the number of reflux episodes, or the proximal extent of reflux. I get phone calls frequently when people or colleagues or nurses or dietitians are struggling with this group of patients saying, well, they're on maximum reflux therapy. And what people mean by that generally is they're on maximum amount of PPIs. And we need to be really clear that the PPIs are not influencing reflux itself. It's much more the esophagitis and the acid-related problems. I think in practice, a lot of prokinetic drugs are used for this group of patients, but what the evidence shows is that the efficacy and safety of the prokinetic drugs, such as metoclopramide, domperidone, erythromycin, has not been studied adequately. So the guidelines say, first of all, that they suggest modification of enteral nutrition with thickening or whey-based formulas, in addition to other therapeutic options in gastroesophageal reflux. They would recommend the PPIs as first-line treatment if we think they've got particularly acid-related problems. And we need to be clear that the ESPGHAN guidelines do not recommend routine use of prokinetic agents, and that's because of their weak efficacy and their side effects. They do concede, however, that in very difficult cases they could be trialled as a short therapeutic trial, and if they work, they could be continued, but if they're not successful in eliminating symptoms, then they need to be stopped. And finally, we look at the nutritional management of poor feed tolerance. What do the ESPGHAN guidelines tell us about that? They talk about using a standard 1 kilocalorie per meal formula is perfectly appropriate. They also look at going up to a 1.5 kilocalorie per meal if there's poor volume tolerance, but making sure that hydration and micronutrients are carefully monitored. They do recommend using a low-fat, low-calorie, high-fibre, micronutrient-replete formula for the maintenance of enteral tube feeding after nutritional rehabilitation has been maintained. And this is something that Rosie is going to be talking to us about shortly. And finally, they recommend using a whey-based formula, particularly when there's reflux, gagging, or retching. So for my final slide, this is the flow diagram that comes in the ESPGHAN guidelines. And if we see gastroesophageal reflux disease, and we're seeing that, follow it down to the yes, they're basically saying, is it controlled with a PPI and the dietary measures that I've talked about, in which case then fine, the child can be fed via gastrostomy. However, I guess the group of patients that I tend to see as a pediatric gastroenterologist are those where it's not controlled by PPI and dietary interventions, and in which case then we're looking for very more specific changes to how the feed is delivered, either gastrostomy with fundoplication or a jejunostomy. So that's coming to the end of my talk, and this was what I'd hoped to get some information across to you. Obviously, it's a very large area. I can only cover a part of that. But next we're going to come to the talk that Lindsay's going to give. Lindsay is a paediatric dietitian who works in Edinburgh for NHS Lothian. And Lindsay's going to talk to us about tube feeding in children with neurological impairment and low energy requirements. Welcome, Lindsay.
Thank you so much, Sue. That was an excellent presentation, giving us an overview of the challenges that we face when we look after these children. So I'm hoping to kind of take this a step further, really, and to build on Sue's talk and to talk more about the dietetic management of the children with neurodisabilities. And more specifically, I want to look at the tube feeding with of children with low energy requirements. So I think as a dietitian, I think this is a challenging area, and I think that is an area where a lot of dietitians might not have much confidence, and with regards to feeding children with low energy requirements. So hopefully we'll be able to look at some of the practical challenges that we face. So the aim of this talk is to discuss nutritional management when tube feeding children and young people with low energy requirements. So first of all, just to give a little bit of a background, I'm the team lead for a group of dietitians working in Lothian. We're quite a specific team that we provide outreach to children receiving home enteral tube feeding. So we've got about 220 patients in Lothian receiving tube feeding. On our specific caseload, on the outreach caseload, we've got about 169 patients, and 130 of them have neurological conditions. So 77% have neurological impairment. So the vast majority of our caseload are children with neurological conditions. The majority of these children have cerebral palsy, congenital neuromuscular disorders, or progressive neurological conditions such as Batten's. We also have children with traumatic brain injury, microcephaly. So you can see it's a very wide range of different conditions that these children can have. And how are we tube feeding these children? So the majority of our patients are tube fed with a gastrostomy tube. We say about 58% of these have a gastrostomy and oral diet. 53% are just gastrostomy alone. And as across many centres, I'm sure in the UK, we're starting to see an increase in the use of blended diets in these patients as well. We've got about 10 patients receiving blended diet, 4 partial blended diet, and 6 full blended diet. Also in this cohort of patients, we're seeing about 10 patients having surgical jejunostomies or a GJ tube or a PEG-J. We especially children with lower energy requirements can kind of fall into this bracket as well. I'm hopefully going to expand a little bit more on that as well. And we have about 10 patients that receive nasogastric feeding, and they tend to be the children who are under the age of 1 that haven't quite come to gastrostomy as yet. So why do these children often have lower energy requirements? Well, they have reduced metabolic rate, usually associated with their neurological impairment and lower muscle mass. They tend to have low tone, which can be another issue with regards to having lower energy requirements. They can have reduced respiratory function. They can rely on ventilation, which can reduce their energy requirements as well. They can have low levels of physical activity. Just the fact they have dysphagia and a requirement for tube feeding can also reduce the requirements. Obviously, eating and diet-induced thermogenesis, we see there is an aspect of calorie consumption with regards to that. So just actually by being tube fed itself can actually reduce energy requirements. Also, we need to look at transitioning for feeding routes, so going from oral to gastric to jejunal feeding. And I'm going to just expand a little bit more on jejunal feeding throughout this talk, because I think that a lot of our patients with low energy requirements do fall into this bracket. So I'm hopefully going to pull out some useful nuggets of information with regards to how to manage these patients, because they can often be quite difficult to manage when they do have low energy requirements. And as I say, 92% of patients suffer from serious GI symptoms, so we do see a lot of these patients either going to gastrostomy and fundoplication or going to jejunal feeding. So Sue has already given a great overview onto the nutritional requirements of children with low energy needs. And ESPGHAN do have recommendations, and they recommend the Schofield equation and the Vital equations. But as you say, this is a starter for 10. These are good reference ranges to use, but certainly it has to be monitored very closely to make sure that we're not exceeding or underestimating these children's requirements. The evidence is that these children have the same protein requirements that any other children have for their age group, and we should be aiming to meet their RNI for protein. Although with children with low energy requirements, it can be very difficult not to underestimate how much protein they give, and sometimes it can be very difficult to give a very low amount of energy and not underfeed them with regards to protein as well. So just making sure that we're not going less than the WHO's recommendations for the minimum protein requirements. As I say, this is all it's all under regular review for patients, so to make sure that we're reviewing patients, I would say with low energy requirements, getting a weights at least 3 monthly to make sure we're keeping on top of things, because energy requirements will change based on age, their weight gain, pubertal development, and their level of physical activity. So Sue's already given an excellent overview on fluid requirements, and I would absolutely agree with what she said. She'd be aiming to meet usual fluid requirements and thinking about special considerations for fluids and electrolytes. So thinking about additional insensible losses that these children might have. They might have increased salivation, they may have ventilatory support, which can be quite drying on their mouth. They might have CPAP overnight, and these types of things which can be quite drying. So making sure that we're looking at all these aspects of with regards to a child's fluid requirements. Thinking about if they have a stoma or if they're generally fed, do they have any bile losses, because thinking about if they have high bile losses, then we need to think about replacing these. And I would say if they're having losses over 20 mils per kilo, then we certainly need to be thinking about how we replace them and how we make sure these children aren't at risk of becoming dehydrated. Constipation is another big factor with regards to fluid requirements, and making sure that if we do have a child that's constipated, that they're getting all their fluid. A lot of these children can be on a lot of medications, so making sure that if they're getting flushes with their meds, looking at volumes of meds, and making sure that we're adding all that fluid into their total requirements as well. And also thinking about children that are non-ambulant. I think that I've seen this a few times. Patients will come out of hospital meeting their full fluid requirements, and actually they can get quite puffy quite quickly, so making sure that we're keeping an eye out for that as well, and just reacting to what we're seeing clinically in front of us. So electrolyte requirements are the same for children with neurodisabilities as they are for the general population. I think that sometimes when we're feeding children with low energy requirements, it's mainly potassium that can be the one that can be difficult to make sure that we're getting in feeds. Oral rehydration solutions such as diurolite or electrolyte. But we've got to make sure that we're using these with caution, as they do add calories when we're adding these into the feed plan. He's generally fed with high with high gastric losses, and sometimes it's a necessary thing to do and add into the equation. So vitamin and trace elements with children with low energy needs. So Espegan gave a very good overview with regards to what we should be aiming for with these patients. And as Sue's already mentioned, these children do have low micronutrients or common micronutrient deficiencies, especially children that are generally fed. We're obviously bypassing the absorption site for vitamin B12, copper and selenium. So these are the ones that we really need to make sure that we're looking out for when we're generally feeding these children. They're also at higher risk of vitamin D deficiency, so making sure that we're supplementing when that is appropriate. Especially during this last few months with COVID and not being outside and not being at school, then it's something that we certainly need to make sure that we are thinking about and is at the forefront of our dietetic management. So feeding regimes, the majority of these children will have will use pumps to deliver their feeds. The reason for that is because it's due to the volume of feed and fluids that these children require. They often have other complex health needs, which means that they they might have time is important to make sure that we're not asking parents to sit and do bolus feeds all day. They've got physio, they've got lots of other health needs that need to be considered. So usually using a pump feed is the best method to deliver feeds. Pump feeding is usually better tolerated in this patient group as well. So sometimes we would use addition of a farrel bag in children that have got GI problems. If they are retching or gagging or having vomiting issues, then a farrel bag can be quite useful to use overnight to decompress the stomach and help with feed tolerance. Feed choices, usually we go for low energy feeds or a complete polymeric feed with fibre for this patient group, and these can range between sort of 0.76 calories to 1 cal per mil. And it's surprising if you look at some of the more complete feeds that some of them can be used from 1 year of age. So just being aware of that, sometimes that can be quite an appropriate thing to do with a patient as long as you're monitoring them carefully. And if you do have a child that has feed tolerance issues, definitely trying a hydrolyzed whey protein feed, is an appropriate thing to do. There's new feeds come out now that are 0.6 calories per mil and suitable for 1 to 10 years. So that's kind of filling a bit of a niche market there with regards to a gap in the market that we had. So, that's an important feed to think about using as well. So, as I say, not to be scared to look at the adult ranges as well, because you might find that there's actually quite a good match within those within that group of feeds. So additions, I mean, I think that if you feel that there's still gaps within the patient's intake, then obviously we need to think about adding some additions into the mix. You can add vitamins and minerals using Ceravit, Flexivits, or just a standard vitamin supplement like a Well Kids or an Abidec. Protein supplementation, we can add protein into feed plans, but as I say, adding protein, you're adding in calories, so it's something just to do with caution, to make sure that you're adding those calories into the total calorie intake for the day. For electrolytes, we can add diurolite and electrolyte. And actually, what we found is if you do need to use these, and mixing them with the feed, if you've got a child who's got quite poor feed tolerance, it can actually be quite beneficial if you mix them together. It can actually aid the tolerance of the child, so it might be something to try. And also considering fibre, these children do require fibre in their diet. It's important to aid for prevention of constipation and healthy bowel motion. So just making sure that we're kind of having enough fibre in the diet, and we can add fibre in if that's deemed appropriate. So assessment and monitoring of these patients. I mean, in Scotland, we've got the QIS, Caring for Children and Young People in the Community Receiving Enteral Tube Feeding Guidelines, and they're quite an old guideline, but nothing has really changed since this has really come out in 2007 with regards to the monitoring of these patients. We would monitor weight and height, and I would agree with Sue, 3 monthly for these patients is quite an appropriate, parameter to be working towards. We don't want to miss any changes with regards to weight progression or any developments in the so we need to make sure we're keeping an eye on that. Nutritional bloods, we would recommend doing them at 2 placements, 6 monthly and then annually thereafter. But what I would say is to make sure that the child is well when we take nutritional bloods. If a child's got an increased CRP, then that can influence the results, so making sure that it is a time where the child is well. I think it's quite tempting if a child's in hospital, we think, oh, let's just get nutritional bloods, but actually we've got to make sure it's an appropriate time that we're taking those bloods at a time. The other thing I would say is a lot of these children are under so many different medical teams. They can be under GI, endocrine, neurology, obviously. So making sure that we're having good communication, with all these teams to make sure we're kind of having a patient-focused nutritional plan going forward. And when we're looking at reviewing these children, thinking about any recent admissions to hospital they've had, any recent illnesses, because this could actually, affect how much feed the child has had, and sometimes it's a knee-jerk reaction to say, oh, the child's not gained weight, let's increase the feed, but it might be the fact the child has actually not had their full feed requirement for a period of a week or so because of the illness. So just making sure we're getting a good clinical history. Any changes to medications can be really important to find out. Any changes to their nitrazepam medication, their tone medications, making sure that we've got a good our epilepsy medications, making sure we've got a good overview of that. Any changes to sleep patterns, pain management, thinking about their tone. I know that I've got some patients who have Botox therapy, and coming up to the requirement for Botox, they actually have higher nutritional requirements and they have the Botox and it goes down again. So actually just being aware of these things are quite important as well. Consider the tube site, especially if they've got a low protein intake. Make sure their skin, as Sue said, is nice and healthy and there's no issues with that. Overall assessing feed tolerance as we usually would, and consider the oral intake as well, because sometimes if you've got a child with low energy requirements who does eat, then it doesn't take very much for them to overdo their energy requirements. So making sure we're having a good overview of what these children are eating orally as well, and just obviously to take all this into consideration, to re-estimate requirements for calories, protein and fluid on a regular basis and update the feed plan. So I just want to take you through just a couple of case studies of patients that I have low energy requirements, and just talk about the management of these patients. So the first one is a little boy. He's 6 years old. He's got microcephaly and leukocephaly. He's got quadriplegic cerebral palsy. He's got primary acquired hypothyroidism, epilepsy, gastroesophageal reflux disease, and he has had pancreatitis in the past. So as you can see, there's lots of things going on here, and there's lots of reasons why this child would have lower energy requirements. And I just want to just talk through his growth chart to see how we've managed this child. So he was first referred to us at the age of 6 months, and the reason he was actually referred to the dietitian was because of actually faltering growth, poor feeding. So at 6 months old, he was commenced on a top-up formula of some Nutritional, really, just to give a little bit extra. First year of life, his oral intake did deteriorate, and an NG tube was passed. During that time, though, he remained on his 1 cal per mil polymeric feed with the NG tube, but it became apparent that his GI function was, very difficult to manage. He had lots of vomiting, lots of retching, and a gastrostomy was placed around about 3 years of age. But despite the vomiting, despite the retching, his weight gain was actually okay. That was absolutely fine. He grew well because he had lower energy requirements. But it got to the point that he had really poor fluid, poor feed tolerance. He was vomiting, he was retching. So we trialled him on a higher energy hydrolyzed feed just to try and get the volumes down to see if that would help. But he ended up on a hydrolyzed feed plan with it on 20 hours of feed a day, which really was not manageable. So we decided to trial jejunal feeding on this child. And as you can see, his weight very quickly escalated right off the growth chart. So in a very short, small space of time. That's kind of what I was saying about, when we change the route of feeding, we've got to be very careful with regards to how much calories we're given and make sure we're monitoring it closely. So after a period of about 4 months, he was transitioned to a lower energy feed, which has some protifar and diorolite added in. But as you can see, even by making that change, his weight gain continued to increase. So at the age of 5.5, this is when I reviewed the child. What we decided to do was try him on a complete feed. So take out the diorolite, take out the protifar, and just feed him, with a complete feed and additional water. So his BMR was 468 calories. What we were feeding him was 468 calories, and that was 41% of his BMR. We were meeting his protein requirements, we were meeting his sodium and potassium requirements, and as you can see, his weight has begun to stable out, which was really important because we couldn't have kept it going the way it was. But as you can see, this is his height above, that we have actually begun to affect his height growth by that. And I think to try and get this child's weight under control, it was necessary to try and pull back the calories. But I think what we need to do now is to try and increase the calories up very slightly to see if we could try and get on top of his height. The added complication with this child is he's just developed early onset pubertal development, so that's another complication that's going to add into the picture. But just to kind of show you how important it is to monitor these children very closely, because things can very quickly escalate. And as I say, it's when you have a child sitting in front of you having 17 calories per kilo, it can be quite nerve-wracking sitting watching, waiting that. But sometimes, as I say, just to get things under control, this is what we had to do in this situation. So at review, we review him every 3 to 4 months. He has a GJ in situ, as I say. The vitamin A level was slightly high, so we're just kind of keeping an eye on that. Stoma losses are good, so he's got no extra fluid requirements, and he's just started on some home oxygen as well. So another reason to try and keep this child's weight, under control when he's got that added respiratory requirement. And that's just to show his BMI has begun to kind of stable off there, but it just shows you how high it was on the growth chart. The second child I just want to talk through is a little girl. She's now 13 months. She's an XPREM, 28 weekers, cystic periventricular leukomalacia. She had a PDA. She had bronchogenetic cyst. So a child who has got complex issues because of the fact she was a preterm, she has got cardiac issues, she's got neurological issues as well, she has got gastroesophageal reflux disease, so a very overall complicated little girl. So she spent the first 6 months of her life in Glasgow and came home at the age of 6 months old. And when she was discharged from hospital, she was discharged on a 1 cal per mil hydrolyzed feed plus with extra fluids. And we had to maintain her around about 100 mils per kilo. We weren't really able to push that much further because of issues with reflux. So what we had to do was we just had to sit and bide our time, with regards to her growth, to try and help it stable out a little bit. So we just kept her at on the 1 cal per mil feed, and very, very carefully watched her grow from 100 cal per kilo down to 57 calories per kilo. She was meeting the RNI for protein at that stage, though, however. But on a phone call to mum, it became apparent, that she really was not doing very well at all, was not sleeping, vomiting. So we tried her with a jejunal feed. So what we did at that stage was we kept her on the on the hydrolyzed 1 cal per mil feed, but we went to jejunal feeding, and we added in some diurolite just to make sure that, because we were going to do some gastric drainage at the same time, so just to make sure that she was meeting her electrolyte requirements. She also started some nitrazepam at this time. She was reviewed by neurology, and she also started some alamemazine, which we sometimes use in children that are prone to retching. Anyway, this child settles out very nicely. And actually, after 6 months, we decided to try her on gastric feeding. So we did a gastric challenge. We used a Farrell bag, and we increased her nitrazepam at this rate as well. So as I say, at this point she was still on the 1 cal per mil hydrolyzed feed with extra diurolite, but at this stage I became quite concerned, because I thought, we think about the longevity of this feed plan. So she was trialled on the 0.6 cal per mil peptamen feed, and her weight has now begun to just very nicely track along, I think it's the 75th centile. We weighed her on Friday, and our weight is just nicely tracking still. So she's now on 800 mils of a 0.6 cal per mil hydrolyzed feed with extra water. Still not great for fluids. As I say, she doesn't tolerate big fluids, but this is just something that we have to monitor and make sure, that we give her extra, if we feel she's becoming dry. So that was just a general dietetic overview of some of the challenges that we face. So, and hopefully we'll be able to discuss and maybe ask some questions on the 2nd of December.
Great, thank you, Lindsay. That was fantastic. Right. So the next talk is from Jodie Walsh. Jodie's a paediatric dietitian with greater than 20 years of experience. She's a member of the American Academy of Cerebral Palsy and Developmental Medicine. And Jodie's going to talk to us now about methods for looking at growth, particularly in the home environment. Thank you, Jodie.
Thank you, Dr. Bunn. And thank you, Lindsay. That was those are great examples of why we need to monitor kids closely with neurological impairment. I'm just going to share a little bit about my experience in the U.S. In taking care of children with neurological impairment at home. And so, during the pandemic, similar to probably how you're caring for your patients, we were using a virtual platform or using the telephone, but we still realized that we needed some way to monitor. And so those are some of the things I'm going to talk to you about today. So we will recognize challenges in obtaining anthropometrics in children with neurodisability, identify anthropometrics that caregivers can do at home to assist in nutritional evaluation, and discuss alternatives to identify malnutrition when anthropometrics are not available. So even when we were seeing patients in person, there were challenges to measuring and weighing children and getting the body composition, the children with neuro disability. And many times they're unable to stand, they have contractures, so it's difficult to stretch them out to measure. They have muscle weakness, involuntary movements. It may be difficult to have them cooperate. Perhaps they have scoliosis, spasticity, or differences in their body composition. So one of the basic anthropometrics is weight. And this was the one anthropometric that we really did try to find a way to get in the home. And many times the caregivers would have a scale at home of some sort, or they would go get a scale. And even if it was a scale that wasn't that expensive, they could use it, and the caregiver could stand on the scale with the patient and then subtract the caregiver's weight. And then we would follow that trend. One of the things we would look at when we were considering anthropometrics is the patient able to stand or walk? We would try to observe the caregiver measuring the patient if they were getting any kind of measurements that we were asking them to give. And so, but once we saw that they could do it, so if they were weighing the patient and we kind of wanted to make sure that they weren't weighing them with all their clothes on, or if they were giving a mid-upper arm, we wanted to watch the technique after we showed them. We would have them do that. Once they showed us they could do that, we would have them do it before the virtual visit, and so that we were all ready with the anthropometric measurement when it was time for our visit. We would request that the same caregiver measure the patient each visit if that was possible. And then, of course, we would document who did the measurement and what technique was used. And then document if they had any kind of cast or medical equipment and what side of the body the measurement was taken on, if they were using any kind of arm measurements. With height, this wasn't something that we obtained at every visit. With the babies, sometimes we would ask the caregivers to get those if we were really worried about an infant being malnourished, and we would be following them, doing a virtual visit, perhaps weekly. Some of the babies that we were really worried about, we would schedule these weight follow-ups, and so in that case, we would also measure their height. And so keep in mind that we're following a trend. We would get them more often in the babies. If the child was able to stand, we would ask the caregiver to do a standing height or recumbent height. But we wanted to remember, it's really important if the patient has scoliosis or contractures, then this isn't the greatest measurement to give. The caregiver could use the tibial length. This just requires a tape measure, but I think, again, you'd really want to be sure that the landmarks they were using were correct. And so if it was possible to show them, on your camera, if you're doing a virtual visit, then that might be a possibility. But for the tibial length, you want to mark at that crease of the inner knee, so that's called the medial joint line, to the distal edge of the medial malleolus, so that's the very bottom of the inside ankle, and you get a measurement in centimeters. When the caregiver gives you that measurement, you could then plug it into one of these equations. Head circumference, we would also get in the infants. Again, this wasn't really something that we were getting that often, and when caregivers are giving these, they're not trained to give these measurements, and so we really want to be careful in how we're interpreting these. So I would say that in terms of anthropometrics, the weight, mid-upper arm, although it depended on the caregiver, how we would evaluate that number. Arm span is another alternate height measurement, and that's where you could have the patient, stretch out their arms. This would really take two caregivers, and you'd measure from fingertip to fingertip, and then plug that number in centimeters into this equation. Mid-upper arm circumference, it does correlate with BMI. It predicts malnutrition-related mortality. It's upper body, so it's typically not affected by fluid shifts unless there's total body edema. It's simple and accurate. Again, we want to remember that in children with low muscle mass, like the children with neurological impairment, we want to be careful in how we're interpreting it, but it can be useful in following the trend. And as I would see children gain weight, I would see increases in their mid-upper arm circumference. And so this is just a little reminder of how to get the mid-upper arm measurement. A lot of times the patient would not be sitting up even, they would be on a table or laying down, if they were at home, they might be in their bed or on a sofa. And so you would have them have their the palm of their hand facing up. You would mark, show the caregiver where the acromion process is, and the very bottom of the elbow, mark the halfway point, and then measure the circumference. So when those anthropometrics are maybe not what we think they should be, so sometimes, we would try to have the caregivers give them, and we'd get the measurements back, and they weren't quite what we thought would be a realistic measurement. And so then we'd have to use other things. And even when we did have the anthropometric measurements, we would always try to do a virtual nutrition-focused physical exam. So, looking at the patient and looking for signs of that underfeeding and overfeeding. And a lot of times, this can speak volumes to us about what's going on with the patient. So we want to look for signs of overfeeding and underfeeding. So underfeeding, we can see bony prominences, perhaps hanging skin. We could ask the caregiver about changes in functional status. So really knowing what the patient's baseline is. So perhaps, the patient was able to sit up and they lost some weight, or they weren't tolerating their tube feeding and now they're not able to hold their head up, or they're not able to sit up. That's a change in functional status. Or maybe they used to roll or scoot around the floor and they're not doing that anymore. That's a change in functional status. And a caregiver may note that to you, and that may be a sign of underfeeding if it's correlating with them losing weight. Overfeeding, again, as Dr. Bunn reminded us, is also a problem. And so we want to be sure that we're avoiding excess overfeeding and then excess adipose tissue, which can make it really difficult for the caregiver to transfer the patient, or for the patient to move around themselves or to do therapy. So some signs of overfeeding we would look for would be, rolls on the neck, looking at the abdomen, looking at the thighs, and just really finding that balance so the child is not too heavy and is not malnourished. So when we're looking for signs of malnutrition or underfeeding, we want to look for fat and muscle wasting. So I'm just going to review the areas for fat wasting as well as muscle wasting. So we'll start at the top of the body, and when we're talking about, one of the areas for fat wasting, those orbital fat pads, which are the fat pads right below the eye, right in the bottom of the eye socket. If those are sunken and hollow and you can see dark circles, that may mean that the child is malnourished, but we can also see that if in dehydration. So we really want to try to sort that out when we're making that assessment. If the child has malnutrition or is being underfed, we'll probably see fat loss in other areas. Another area would be the buccal fat pads. And that is those are the fat pads right below the cheekbone. And in a child that's well-nourished, the cheek should be round and filled out. In a child that is malnourished, we may see sunken, hollow areas. Another area for fat loss would be the triceps. And so similar to how we would get a tricep skin fold, you would look at the triceps and then look at the, you can have the caregiver do a pinch test, but we really want to be sure that they were separating that muscle from fat. And since we're not able to do that ourselves virtually, that may be something that we're just kind of observing, looking at the arms, looking at the legs. Another area that we could look at or have the caregiver look at would be the ribs. And if we can see separation between the ribs, or we can see all those bony prominences, this may indicate that the child is being underfed. When we talk about areas of muscle wasting, again, going and starting back up at the top, one of the first areas that we may see changes would be that temporalis muscle. And this muscle may not be that well developed in children with neurological impairment just because they may not be chewing, which can lead to some underdevelopment of that muscle. But also in severe malnutrition, you may see this muscle is very wasted and sunken and almost scooped like a big depression in the side of the head. Another area would be the clavicle. And this is where you're looking at the pectoralis muscle. And in severe malnutrition, you can really hook your fingers right up under that clavicle muscle, clavicle bone, because there's so much muscle wasting in the chest. Another area may be the back. And so looking at those muscles in the back, like the latissimus dorsi and the rhombus muscles and the shoulder muscles. In children who are well nourished, we may still see that scapula, but when we feel for those muscles around there, we would hope that it's not too wasted. Now, what we really do need to keep in mind when we're looking at muscle loss, that a lot of these children, they may not have great muscle tone unless they have sometimes I'm really surprised just with the amount of spasticity they have. Sometimes the muscles in their arms are extraordinary, just because they're so tight. But really, when we're looking at muscle loss, we really do need to keep in mind what their baseline was and what if they had any muscle mass before. Same with the shoulders. When we're looking at the deltoid muscles, if we can see the bony prominence, like the acromion process really sticking out there, and they've lost all that mass in their shoulder, we may be concerned. Again, we're going to combine our physical assessment with looking at, how are they eating, how are they tolerating their tube feeding, and we put that together with our assessment of muscle and fat wasting. We really want to be careful when we're assessing muscle wasting in the lower extremities in children that do not walk, and so we would expect there to be wasting in the lower extremities. However, I always still looked closely at the quadriceps and the calves, because if the children were malnourished, I might see hanging skin. So maybe it was their legs had more of a circumference before, and then they lost weight, and then I could see hanging skin, and sometimes their legs would just be so bony. And so even though we wouldn't expect them to have huge muscles, if we combine, our physical exam of, looking at the legs and along with their weight history and their intake, it helps us inform our decision about whether we're overfeeding or underfeeding. Again, the calf muscle, we want to look there too and just see, is it flat? Is it, in well-nourished children, a lot of times it's bulb-shaped and more firm. But again, we need to remember, if they're non-ambulatory, this muscle might not be that well developed. But again, I can't stress enough that, I've seen so many children with malnutrition, and as they're repleted, we do see changes in their lower extremities. So it is something to physically look at. We just need to keep that in mind as we're doing our assessment. So Lindsay did a great job in talking with us about nutrition interventions, and so I will kind of go through this very quickly, but obviously if the child's underweight, we're going to increase calories, and ways we can do that. We might increase the volume, use a higher calorie tube feed, or add additional feeds, or perhaps even consider adding a night feed if they're having volume problems. If they're overweight, we could decrease the volume or consider using reduced calorie tube feeding. So in talking about these children with neurologic disability, we know it's so important to monitor them even when we can't see them in person. And so if it's at all possible to use a virtual platform, and the caregivers have the technology at home and you have the technology to do a visit, I think there's great value to doing telehealth and seeing the child. And so when we would do our visits, we would have the patient there with the caregiver, and we would ask them to, can I see their belly? And then if possible, we'd want to see their back and their legs, and we would try to do that virtual physical exam. We'd want to get a detailed intake, get a detailed history, assess for constipation, reflux, all those questions that you would normally ask, during your visits. You can ask during your virtual visit as well. If you don't have that virtual platform, you can use email. One of the things that we did in the children that were severely malnourished to monitor them is every 2 weeks we would request that the caregiver send photos, and we could look at the changes over time. And we would ask the caregiver to take a picture of their face, chest, abdomen, their back and their legs. And this was extremely helpful. And then I could share these photos with our medical director and the team, and we could kind of assess, how the patient was doing as we were adjusting their nutrition regimen. And this was something that we found very helpful. Again, before I would do this, I would have the caregiver sign a photo release form. This was a requirement at our hospital. Now, let's say the caregiver doesn't have email or the technology for a virtual platform. You can ask questions over the telephone and just ask the caregiver if the child appears, heavier or thinner. Are they more difficult to lift or move? Or do you notice that the size of their clothing has changed? What's their energy level? All those things that you would ask during your visit before, you could ask over the telephone. Again, then we want to adjust that nutrition plan to avoid over and under feeding, and then monitor closely. And one of the things that we really found was sometimes in the children that were malnourished, and they may be malnourished because of their neurological impairment and perhaps dysphagia, or they may not be getting their full tube feeding or tolerating it. But sometimes it may be social reasons or environmental reasons. And that group of patients was more difficult for us to monitor in terms of them coming into clinic, and we did not go out to the home. We would have them come to clinic. And what we found was we were actually able to reach that group a little better with these virtual visits. And the caregivers were actually really open to this, and look, they would ask for their next visit, when it would be. And so I think, we learned a lot as a result of, I guess you could say, being forced to do the telehealth. But with this population, I think there is a use for it. And it's so difficult to bring the children into clinic, and sometimes they may be on a ventilator or in a wheelchair or on a stretcher. And so I think, this has taught us that there are ways to monitor. We just have to remember not to get too caught up in an objective number, to look at the trend, look at the physical exam, and then monitor closely. And that concludes my discussion. I'll turn it over to Dr. Bunn.
Thank you, Jodie. I completely agree. I agree that I think, though COVID's been very difficult for all of us, it has actually helped us look towards managing children outside of hospital and reducing their number of visits to the hospital. Fantastic. So does that bring us all of our presentations to an end? I hope it's helped you develop a better understanding of what we aim to do, which is trying to understand how to meet the nutritional requirements of children with neurological impairment. We will now move over to the live session, which we'll do our best to answer all your questions. We have about 20 minutes for questions, and what will happen is we'll answer the vast majority that we can, but if there's any we can't, then we will try and do written answers to those questions and put them either online or email them through to you. So we'll move now to the live session. Speak to you very shortly. Great. I hope everybody found that really helpful. I'm Sue Bunn, as I say, I'm a paediatric gastroenterologist based in Aberdeen, and I'll be chairing the sort of questions section at the end. We've had some great questions come through, so we'll start straight away. I'll try and sort of cohort them a little bit to some of the speakers. So the first question is from Jalai. I can't see today actually where you're from, but the question was, how much fibre, grams per litre or grams per day, and which type of fibre would you recommend? Jodie, could we come to you first, and then perhaps Lindsay, could I have some comments from you as well?
Sure, thank you, Dr. Bunn. What I've seen with fiber over the years is there's definitely a role, but if we give the children too much fiber, it can delay their gastric emptying, and because the tube feeding or food could potentially sit in the stomach longer, making reflux worse. The other thing is if they're, they have the poor tone throughout their bowel, and we load them up with fiber, we could then make a huge bowel movement, which is harder for them to push out. So just being careful with the the amount of fiber that we're giving, keeping in mind if they have reflux, we could potentially delay emptying.
That's great. Okay, Lindsay, have you got any comments?
Yeah, I would agree with what Jodie has said, and I think sometimes, parents are, it's one thing parents ask about is fibre, they want to make sure their children's getting enough, and I think that we would always go for a fibre-containing feed, as first line, and, if I felt that any additional fibre was needed, a soluble fibre would be the fibre of choice, and something like an optifibre would be, something we could add in if needed, but yeah, absolutely do it, very small amounts and very gradually would be the way to go, definitely.
That's great, thank you. I mean, I think the other comments over the sort of constipation side of things, which I guess is where I come in, is that sort of focus on fluid is really important as well. And I guess I would add that, when we have moved over to blended diet in children with very difficult constipation, we've seen quite remarkable improvements in their constipation. So that's something to bear in mind as well. Coming to the fluid, there is a question about fluid. So it says, in terms of fluid requirements, is there a safe minimum? This is from Deborah Griffin. I was taught that for children with neurological impairment that they had a lower metabolism to reduce water requirements by 10 to 20%, 10 to 25%. I'll come in first and just say I think it's very reasonable to consider. I certainly, when I've got children with high adiposity losses or high gastric losses, I'm relatively comfortable to let them lose 15 to 20 mils per kilo before I really get concerned about that. What I would say about this group of children is that they do have increased fluid losses as well. So you need to bear that in mind. A lot of these children are drooling. I've had parents who actually weigh the muslins that they're catching the drool in, and you'd be shocked how much, hundreds of mils that they're losing in a daytime just through drool. And I think obviously for some of the children who've got gastric drainage or they're vomiting, you have to be aware of the amount of fluid they're losing as well. But I'll come to you first, Lindsay. Have you got any comments on how you manage fluid intake for these children?
Absolutely. I think you've got to take quite a pragmatic approach to the fluid management of these children. And we would always start, by working out the maintenance fluids, but then recognise, as you say, some children might need a little bit less, some children might need a little bit more. So it's all about monitoring and asking the clinical questions about wet nappies, constipation, drooling, dry mouth, all the clinical, features of dehydration, making sure we're looking at that. So, just kind of taking an open approach to it, I think, is quite important, just monitoring the situation.
Great. One of the questions we've got is about diaurolite. Here we are. So Hannah Morden has said, do you routinely add diaurolite to meet potassium requirements, or do you only use if indicated from blood tests or special cases? Jodie, can I come to you with that one, please?
Sure. Yep. So we always do an analysis of all the micronutrients in a child that's tube fed, and for potassium, we would always want to get close to a milliequivalent per kilogram of their body weight. Now, I used to actually use a lot in the U.S. We might say like a Pedialyte or oral rehydration solution, which has 20 milliequivalents per liter of potassium. And what I found was, if this is something, if they need it every day, and that's a lot of liters of fluid in addition to their tube feeding. So storing, this electrolyte solution versus, just giving them a supplement is what over the years I found to be more effective. So sometimes if their tube feeding was not providing enough of potassium, it may have also been low in phosphorus. So we would use a medication, Nutriphos or a powdered phosphorus supplement with potassium in it. But again, I think that's the beauty of, some of these, the formulas with the reduced calorie, because they have the electrolytes in them. And so you're not asking the family to give another oral rehydration solution or a medication, because if they overdo it on the potassium, that could be bad too. So I do think that's an advantage of the reduced cal formula. I found I haven't needed to use as much of the supplements.
Great, that's really helpful. Would you come in as well, Lindsay, on that, if that's all right?
Yeah, I absolutely agree with what Jodie says there. The diorolite is, as you say, only 2 millimoles per 100 mils of, potassium, so it's relatively low. Something for like a paediatric sedative might just give a better, overall intake of potassium. So yeah.
Yeah, and I think the point you make, Jodie, as well about using the low-calorie feed is excellent. I say it frequently. By the time we give somebody 1.5 kilocalorie per meal feed, and then the parents are having to use extra water, they're having to use extra flushes, they're having to use extra electrolytes. I think thinking it through and using something that covers all those bases is actually very, very sensible. Okay, so I think we've got a question about copper. I'm just trying to find it now. It was basically saying, do we see copper deficiency? Here we go. What all supplements do you recommend for copper deficiency in a tube-fed child who has feed tolerance issues, and how much would you give? I think it's probably better to come to you for that, Lindsay, because I think you touched on this briefly in your talk.
Yeah, absolutely. So we have seen some copper deficiencies, but it's mainly in our jejunally fed children, and the reason for that is because the absorption site for copper is in the in the duodenum, so in the very start of the small bowel. And sometimes what can happen if you're jejunally feeding and you're bypassing that absorption site. So we've had maybe 3 or 4 patients that we've had to supplement with copper that have been jejunally feeding. I don't think I've had any gastrically fed children that have had copper deficiencies. So the way we manage it with regards to jejunally fed children is we use copper sulfate, and we very much work closely with pharmacy and work closely with the GI consultants, and they're the ones that monitor the nutritional bloods for these patients very closely, and advise on the prescribing of the copper. So it's something that very much that is especially made for our children here in Edinburgh. So it's something that is close liaison with pharmacy and close follow-up as well to make sure we're not overdoing it or underdoing it as well. So it can be quite a serious issue, having prolonged copper deficiency. So something's got to be taken quite seriously and managed really, really closely and appropriately.
Yeah, I would completely agree. I think probably the question it leads into next is one from Jalil Benakoop, who said, it's actually a question to me, but I think actually we all should try and answer it. So the question is, how do ESPGHAN guidelines used in daily practice? Do you see challenges to apply them for systemic nutritional screening in CP patients? So because of all the reasons we've discussed, and because that we recognise, and I think I showed you in my slides, the proportion of these children that are micronutrient deficient, I think actually it's a really critical part of our management is to recognise that and to screen them regularly. So we do screen them on an annual basis, in my present practice. I think the part of the ESPGHAN guidelines that I don't think we do concur to in Aberdeen where I work, and I don't recall in previous centres I've worked, is the recommendation that we do DEXA scanning regularly, and I think that's partly because of the access, within the NHS to DEXA scanning. I'm sure there are parts of the country that do that regularly, but I think that for all the reasons we've talked about, the absorptions of some of these micronutrients within the jejunum, cutting back on the 1 kilocalorie and 1.5 kilocalorie meal fills, recognising there's a lot of micronutrient deficiencies, it is critical that we monitor them. Do you want to come in and just comment on that as well, perhaps, Jodie? What do you do in the States?
Yeah, I agree with you for the DEXA scan. It's not something we routinely do. If we have someone with repeated fractures, they may end up seeing endocrinologists and then considering bisphosphonates or additional treatment. But it's not standard and as part of screening. We definitely are screening for malnutrition at every clinic visit when they come in or when they come into the hospital on the inpatient side. In terms of body composition, I think, as you mentioned in your talk, looking at, the weight for height is not helpful. So doing something to assess their body composition, like the tricep skin folds. And so that's something that we would routinely use to assess body composition.
Great. And what about you, Lindsay? What are your feelings?
I would agree with everything that's been said, yeah. And I think that in Scotland, we're certainly looking to try and do more tricep skin folds, and we're actually producing a guideline within Edinburgh, to try and get a bit better at that, because that's something we certainly fall down on, I would say, so I think we need to try and get better at doing that, to try and get more parameters for, assessing these children. The other thing I would say is that what we've done in clinical practice is we actually have, the dietitians in our team have access to ordering nutritional bloods, and I think that's something that's really important, because these patients can be under so many different teams that it's like, oh, who's going to take responsibility for doing the annual nutritional blood? So I think if you've got a dietitian who's involved really heavily with these patients, if they're able to take that responsibility, make sure those nutritional bloods are done, and feeding back to a linked consultant if there's any issues with that, and I think that's really good as well, just so making sure that that these things don't fall through the gap because someone else thinks someone else is doing it when maybe they're not doing it. So that's something that's worked really well for our team.
Yeah, we do the same. Our dietetic team in Aberdeen do the same. I'll come to this one. It's a slightly more medical tilt on it. So this is Diana Walsh. She said that many children with severe neurological impairment and underlying epilepsy on multiple medications. She describes that many of them have these thick mucus vomits, and that are very challenging. And what she's saying is, are there particular medications that increase mucus secretions? And is there anything that can be done medically to reduce these mucus vomits or mucus secretions and improve tolerance to feed, where all dietetic options are being exhausted? What I would say, it probably perhaps fits in more to the talk we did a couple of weeks ago, but most of these children have a dysmotility of their foregut, so their stomach doesn't empty particularly well. I think it's a combination of things, and I think a lot of these children obviously have a background with respiratory issues, so they're probably increased the upper airway secretions. We give them drugs to thicken their secretions, so they then swallowing down very, very thick secretions, and then these thick secretions are obviously sitting in the stomach, and then very unpleasant when the children are vomiting them. And as you quite rightly point out, they are quite distressing for the families to see that. I have to say, if I see a child with very difficult vomiting issues, then I would be thinking about, well, actually, is it going to be beneficial to drain this child's stomach at the time that we're feeding them? So it may be an indication then for a trial of converting their gastrostomy to a gastrojejunostomy, giving some of the feed jejunally, and then actually draining the stomach of some of the mucus to prevent these nasty symptoms. So I think in that kind of scenario, I would suggest that you discuss that further, probably with your local paediatric gastroenterologist. I think we've got time just for a couple more questions. So I think this is an interesting one. So Jale has asked, is in overfed patients, what is the most common comorbidity or complication that you observe in your clinic? Should I come to Lindsay first for that one, please, Lindsay?
For overfed patients, most common comorbidity, I suppose, is my biggest concern is their respiratory function. I think if we make these children too big, then they can compromise their respiratory function. So I think that is a big consideration for us. As we think about the impact of carrying that extra weight for these children, and also just their daily physical life, and getting the quality of life. If we're making these children, or if these children are quite big, how that impacts on their quality of life, and their ability to engage in activities and so on and so forth. I'm not sure if I've answered that 100%. If there's another part to that, Sue, if you think that does that cover
I think that's very helpful, Lindsay. I think the other thing, we'll pitch it quickly to Jodie as well in a second. I think the other thing is the bone health side of things. My feeling is that the children that we see with most of the femur fractures are probably those that are slightly heavier, because they are more difficult for parents to maneuver. So I think when I gave you the list of risk factors for fractures, a child being overweight, a higher body fat was one of the risk factors, and I think we need to recognise that as well. Have you got any other further questions, comments, Jodie?
Yeah, I think, everything that the two of you have said definitely I've seen true in clinical practice, but also in some of our older kids, the teenagers that have maybe been overweight for a while, or the young adults even, when we will check a hemoglobin A1C and see that that's elevated, and then when we actually start cutting back on their calories, we'll see that we're increasing those insulin receptor sites and their hemoglobin A1C is improving. So I do think, sometimes those same comorbidities that we think of with obesity, we're not looking for those as often in our clinic unless it's really, something like with our older kids, we're a little better at screening for things like that. But I have seen that in kids that are overweight, and also some skin breakdown because they're not being moved as often as they should be, or it's harder for the caregivers. And so I feel like they're at a little higher risk for maybe some skin problems if they become too heavy and they're, severely neurologically impaired and unable to move themselves.
Great, that's helpful. We'll just stay on that theme slightly because it's partly what we were trying to do. Just very quickly, it says, this is from Leslie Gallagher, have we managed successfully to feed children with low energy requirements with blended diet? Achieving adequate protein in these blends is a concern. Do you recommend vitamin supplements? Because we're running out of time, I'll just answer that very briefly. We had a really good webinar a couple of weeks ago, and actually one of the very experienced dietetic speakers there was very strong to recommend that these children should have a standard diet. And so in the same way as if we would want to, for an adult, we would want to cut down on some of the macronutrients, the calories, we can still do that in a blended diet, but actually make the blended diet very nutritionally complete. And obviously a food diary would actually check that as a dietitian. So I don't think, and she was not advocating recipes, and she wasn't advocating for sort of supplements to blended diet on that basis. And finally, I think probably we're going to have for the last question. It was coming to Lindsay for the case study you shared. She said, thank you for the presentation. I'd like to ask Lindsay, for the case study you shared, was the child's length height always around the 0.4 centile when he was younger? My second question is, if a child has a very small build, for example, weight is less than 0.4 centile, but in proportion with the height and has been growing along the same centiles, would you recommend to aim for meeting nutritional requirements with age, or does this child need less? Could you answer that for us, perhaps, Lindsay?
So the first part of that question was his length always around the 0.4 centile? Yes, it was. I think it always. I don't have all the data for that because I didn't look after him at that point, but he was certainly, on the lower end of the growth chart. My second question is, if a child has a very small build.
Yeah, it was if it has a very small build and is growing along the 0.4 centile, would you just do it? Would you do the requirements for age, or does the child need less?
I would do it for age. I would always aim for micronutrient requirements for age. Sometimes there's not that big a difference, between sort of a couple of years difference anyway when you look at it. But yeah, I would always aim for requirements for age, especially vitamins and mineral requirements.
And actually, that answers one of the last questions we haven't answered. So Denise McCarthy has said, in Fertility Thrive, you work on macro and micronutrients for height, age, or actual age. So I guess you said to us you'd really look for actual age. Is that correct, Lindsay?
I would, especially when it's micronutrients, when then there's actually not, if you look at the sort of the range, and there's not usually that big a difference between them, and we're not going to have any implications with calorie intake, with just making sure these children are getting their micronutrient requirements. So I would always go for their actual age requirements.
Fantastic. So thank you for the audience. I mean, there's been some brilliant questions come in. I think we've pretty much answered all of them. What we can endeavour to do, if there's any questions we haven't answered when we go through, because they've been coming in as we've been answering, is to try and answer those and put them onto the hub so you can see the answers to those. So I'll draw this webinar to a close. What I'd like to ask you is to go to the home page and do the evaluation form. That'd be very helpful for all of us. And it's also to let you know there's a copy of all of our slides there if you'd find them useful. So thank you all and good night.